All right, let's get into it. Today, we're talking about a condition that's as sneaky as it is deadly, one that hides in plain sight in our intensive care units: abdominal compartment syndrome. It's a fast-moving, devastating process, and if you care for critically ill patients, you absolutely need to know about it.
You know, in the ICU, we are glued to our monitors. We watch heart rate, blood pressure, O2 sats. We obsess over them. But what if I told you there's another pressure, a hidden one that's not on the standard screen, that can bring the entire body to a screeching halt? Well, that's the pressure we're going to uncover today.
Okay, so to really get this, I want you to picture the abdomen as a pressure cooker. A little bit of pressure, that's totally normal. But when that pressure starts to build up and up with nowhere to go, well, that's when you've got a crisis on your hands. To understand where that line is, we have to get a few key definitions straight first. So everything starts with this one number, intra-abdominal pressure, or IAP. You can think of it as just the normal, steady-state pressure inside the belly. Now, for someone up and walking around, it's practically zero. But for our patients in the ICU, we expect it to be a little higher, somewhere in that 5 to 7 millimeters of mercury range. This number is our baseline, our starting point for everything else.
Now, pay close attention to this slide because this is where we separate the warning shot from the actual disaster. On the left, you've got IAH, or intra-abdominal hypertension. This is when that pressure stays at or above 12. Think of this as the smoke alarm going off. It's a critical warning. But on the right, that's ACS, abdominal compartment syndrome. This is when the pressure blows past 20 times, and this is the key part: we start to see new organ failure. That's not the alarm anymore. That's the house on fire.
So how does that pressure cooker get so dangerously full? Well, there are really four main ways this happens. First, the container itself can get stiff and refuse to stretch. Think of a patient with massive burns, or a surgeon who closed the abdomen too tightly. Second, you can just have more stuff inside, like a big bleed from trauma or tons of inflammatory fluid from pancreatitis. Third, the organs inside can swell up, like with a nasty bowel obstruction. And then there's the fourth one, and this is a biggie for us in the ICU: our own treatments. When we pour in massive amounts of IV fluid for sepsis or trauma, all that fluid can leak out and cause everything to swell, creating the very crisis we're trying to fix. Okay, so we know what it is and how it starts. Now let's look at how this thing turns into a full-blown catastrophe. This is the how it kills section. See, once that pressure gets too high, it doesn't just stay put. It kicks off a devastating domino effect that takes down the entire body. And this slide lays out that vicious cycle perfectly. The abdominal pressure skyrockets, and it starts to squash everything inside. The big veins that bring blood back to the heart, they get flattened. So less blood gets back to the heart, which means less blood can get pumped out. Your cardiac output just tanks. And when that happens, every single organ, from your brain to your toes, gets starved of oxygen. That's when multi-system organ failure kicks in. It's really just a simple, brutal mechanical problem. This diagram really shows you the heart of the problem. You can see how that pressure in the abdomen just radiates outwards. Look how it shoves the diaphragm up, crushing the lungs and making it impossible to breathe. It squeezes the life out of the kidneys, shutting down urine production. It even backs up pressure into the chest and head, raising intracranial pressure. It's a total body assault, and it all starts from that one central point of pressure. Okay, let's run through this rapid fire. Cardiovascular, less blood in, less blood out. Simple. Pulmonary, the lungs get squished, ventilator pressures go through the roof. Renal, the kidneys don't get enough blood, so they fail. Hello, acute kidney injury. Brain, pressure goes up, blood flow goes down. And the gut, it starts to die, which can then poison the whole body with bacteria. Every single one of these is a disaster. So, given how incredibly deadly this is, how in the world do we find it before it's too late? This is where we put on our detective hats. This is the investigation. We absolutely cannot guess here. We need cold, hard evidence. We need a number. And here's something that every single one of us needs to remember. You can't trust your hands on this one. You might think you can feel a tense, swollen belly, but the research is crystal clear. The physical exam is just plain bad at this. Some studies show it's only about 40% sensitive. That means we could be missing over half the cases if we rely on feeling the abdomen alone. So if we can't feel it, how do we find it? We measure it. And the gold standard is actually pretty clever and simple. We use the bladder. All you do is put a tiny bit of saline into the bladder through a Foley catheter. The bladder then acts like a little internal balloon, and it transmits the pressure from the abdomen to our monitor. The key things to remember are: get the patient flat, zero your equipment at the right spot on their side, and get your reading when they breathe all the way out so their muscles are relaxed. Once you get that number, you can grade just how bad things are using this system from the World Society of the Abdominal Compartment Syndrome. These are the folks who write the rulebook on this. A grade I from 12 to 15 means you better start paying very close attention. Grade 2 from 16 to 20, now things are getting really serious. And once you're over 20, you're in deep trouble, grade 3 or 4 territory. This scale is what tells us how aggressive we need to be.
All right, now for the part that really matters. What do we do about it? We found the pressure, now we have to release it. And the way we manage this is like climbing a ladder. We start with the simplest, least invasive steps and only move up if we have to.
So Tier 1 are first moves. A lot of these are common sense, but they can make a huge difference. We try to make the container bigger, get those tight binders and dressings off. We try to empty things out with NG tubes and enemas. If there's a big fluid collection, maybe we can drain it. We relax the patient's abdominal muscles with good sedation, maybe even a paralytic. And a huge one, we lay them flat, because sitting a patient up can actually make the pressure worse. Fluid management, this is maybe the trickiest part of all. It's a real balancing act. We know that giving too much fluid can cause this problem in the first place, so we have to walk this tightrope. We need to give enough fluid to keep the organs alive, but not so much that we fuel the fire. This means we have to be smarter, avoiding endless bags of saline, maybe using different types of fluids, and really trying to get that fluid off by day 3. It's an hour-by-hour struggle. But what happens when you've tried everything and the pressure keeps climbing and the organs are failing? Well, at that point, medical management has failed, and the experts are very clear. You have to operate. A decompressive laparotomy is the last and only life-saving option left. And this is what that looks like. I know, it's a dramatic image, but at this stage, it's the only thing that can save their life. The surgeon literally cuts the abdomen open from top to bottom. It's like taking the lid off the pressure cooker. It immediately releases all that compression on the organs. Then, a special dressing, often using a vacuum system like you see here, is put on to protect everything until the swelling goes down enough to close the belly for good, which could be days or even weeks later. So, we've been through the what, the why, and the how. Let's finish up by talking about the stakes here, and more importantly, the real key to survival. And it's not just about treatment, it's about getting ahead of the problem. And the stakes, well, they couldn't be higher. Even when we do everything right, even when we do that big surgery, the mortality rate for full-blown abdominal compartment syndrome can be as high as 76%. Just let that number sink in for a second. 3 out of 4 can die. It is an unbelievably lethal condition once it gets going, which is exactly why everything we've just covered is so critical. So, if you remember one thing from this entire discussion, let it be this. The key to survival is not treating the crisis, ACS. It's preventing the warning sign, IH, from ever turning into the crisis in the first place. And that's a simple 4-step mission. Screen every patient at risk. Measure their pressure if they have those risk factors. Monitor it if it's high. And most important of all, act early. Jump on it with those medical therapies the second you see IH, long before the organs start to shut down. Which really brings us to one last question. We're all so good at watching the heart rate, the blood pressure, the oxygen. But after hearing all this, the next time you walk up to that really sick patient, the one with bad sepsis or trauma who's gotten tons of fluid, I want you to ask yourself, what's the one vital sign I might be missing?